We'll get going. It's brilliant to see you all here. My name's Ed Jones, and I'm going to be chairing and facilitating the conversation this morning, which, as you'll be aware, is on the role of diagnostics in elective recovery and a wider transformation in the NHS. My name's Ed Jones. I'm a senior partner, co-founder of a consulting business, New Market Strategy, and in a former life, I spent 6 years as Special Advisor to the Secretary of State for Health, Jeremy Hunt. And if you can remember that many health secretaries ago, he's the one who hasn't been eating camel penis in the jungle or isn't back as Health Secretary. We've got a great panel with us this morning from who'll bring a variety of perspectives, and I know that we've got a really well versed and a good spread among the audience as well. So we look forward to hearing your questions. Just to introduce our panellists, we have Neil Anderson, who is Clinical Director of Diagnostic Services at University Hospitals Coventry and Warwickshire. Teresa Shapland, Strategic Relationships Director at our sponsors and supporters BD. We have David Wells, Chief Executive of the Institute of Biomedical Sciences, and David, formerly Director of Pathology Transformation at NHS England, and Jill Crankshaw, who is Associate Director of Strategy and Transformation at Lancashire and South Cumbria Pathology Service. If you would like to submit a question via the tech gizmo at any point, please do. I should be able to pick it up here. Obviously as well, if you would like to raise a hand, perhaps we'll find some time for questions at the end of the session. If I could start off perhaps by coming to you, David. Having spent now, a year outside of your role at NHS England, and reflecting on the state of the diagnostic infrastructure as you bequeathed it and the leadership of that transformation agenda, where do you think we are at, and what possible role do you think, what's the opportunity for diagnostic services to contribute to this huge elective recovery challenge that we've got in front of us?
Well, we're actually in a very good position, actually. I think if I go back to when I started the transformation work in 2017, I think pathology services and the imaging services that form the whole diagnostics programme were actually in a very disconnected position. They were not that well funded. They had a lot of pocketed poor service, some examples of really good service, clearly, but again, it was across the country. You wouldn't be able to bring those together to tackle such challenge we have at the moment. The pathology services and the imaging services we brought forward into networks gave us a fantastic launch point as we went into the pandemic, particularly to bring together a lot of the COVID testing and to corral a lot of the need in imaging that was going on during that time. And that really, that networking and the leadership that went into those has given us at the outpoint an excellent staging point to really get hold of a lot of that spare capacity and the lack, identifying the areas of lack of capacity to take us forward into the next period. Also, during that time, we've had the Richards Review that talks about the CDCs, etc. And also the public agenda around diagnostics has become far more visible. So actually, we're in a very strong position, I think, to take forward and tackle that. That doesn't mean we're in a good position, I think, I'll add. We've got massive workforce issues in terms of the number of people who are out there to be able to provide services, and we still have a huge disconnect between what we have on the ground and how it functions. But I think the policy is in the right place. I think we're seeing investment coming through at a rate that I think any of us have seen, haven't seen before. And we've got the march towards a lot of the digital infrastructure that's going to be essential to bring those bits together so we can use the right capacity in the right places. And again, read back to the CDCs, but also the pathology networks, which means actually as we go through the elective recovery piece, we can bring more work through and tackle those backlogs. So long and short of it is, I think we're in a very good position. Could be better, but there's still lots to do.
Great, thank you. There are obviously lots of themes in there that we'll come back to: workforce, funding, investment, community diagnostics, pathway change. If I could just ask perhaps our two panellists who are leading this service delivery and transformation on the front line, is the picture David presents one that is familiar to you, and how do you see that playing out in the short term?
I think when we created networks or we came up with the network methodology, we weren't in a place at that time to to work together, because we'd always competed against each other as trusts. But I think perversely COVID helped us in that, because actually we had to work together to ensure we had enough testing and to think differently about how we were going to do it. So actually, in one sense, it's made us come together and form networks and create relationships, both within our pathology network but also across nationally as well. We were just talking, David and I, when we were going through the COVID pandemic, we probably talked to each other every day, you know, because there was a need to do that, because we had to manage things on a day-to-day basis, didn't we?
Absolutely, yes.
What about you, Neil?
I would agree. I mean, with both David and Jill on that. I suppose I'm quite impatient for change generally. And David probably can't remember, but I said National Pathology Board, must have been about a year and a half ago or something. All right, so we've created networks. What do we want to do with them now? You know, we can create super efficient networks. We can bang down the cost with suppliers. We can work it out. But actually, what do we want to do? And I think where we need to start to think now is about the value that pathology adds to patient pathways. So when we're talking about how we're going to help elective recovery, how we are going to help any number of the waiting lists that are around, it is by understanding the value of pathology that it can add to the next step. And I think that's definitely where I would certainly see a focus, and that's certainly where a lot of my academic interest is.
Teresa, presumably that's an agenda which, you know, corporate partners have got to play a pretty important role in and supporting. Is that the I assume the case at VD too? Yeah,
I think things are changing. I think it's such a complex environment now, especially with ICBs really starting to take hold. I think it's interesting to see how this maps out, but certainly the pandemic, and I think you can't talk about anything without talking about the pandemic quite quickly, has changed how we view the role of diagnostics. And certainly from an industry side, it's the same. We see a renewed interest in how they fit into that pathway.
And before we move on to the more future facing, I mean, Neil, the COVID experience, the NHS pathology infrastructure did have its detractors, its critics, and some would have it as the breaking of the system, and others would say the making of it. I mean, what's the truth, do you think, from somebody kind of running services on the front line?
So I mean, I think the pandemic was really interesting in healthcare in general. So the pandemic happens. What happened first, certainly in my organisation and in my wider hospital organisation, and then in pathology, was that a lot of the clinicians got together and worked out what those pathways looked like, how we would triage patients, how we would look, how we would support. And you know, I'm a pathologist, and not only did we provide COVID tests, but actually we provide a lot of the diagnostic tests that actually clinicians relied on for the patient journey through the trust and the eventual discharge. So I think there was something coming together and designing pathways and everything like that. I think the response to COVID, probably it was a bit irritated in the first, that actually the assumption was made that pathology couldn't respond straight away and didn't have that capacity. So there probably was a little bit of, well, we're going to show you a bit. But actually under David's leadership, actually we all came together as a pathology community and started to deliver. Of course, we whinged incessantly at the sort of the press releases that came out, or I forgot what they call that. Anyway, when Boris would stand up and say, we're going to get to 100,000, or we're going to get to this, because frequently no one had a clue on exactly how we would get there. But we all responded, and I think that was really good. But going back to one of David's points about digital infrastructure and investment in digital infrastructure, what we quickly found was that a digital infrastructure was essential to deliver the COVID response, not just in terms of the identification of individuals in the community that may have COVID, but actually sight of that in a primary or secondary care setting.
I think the theme of what we've learned in terms of service delivery, but also in terms of population health prevention, consumer engagement from the COVID experience, I think will we'll come back to that.
If I could just, so my own strong reflection on COVID was, so I was a professional leader at the time, and when lateral flow tests came in, so as a pathologist I was saying lateral flow tests are rubbish. They are just, it's the end of the world if we're going to do something like lateral flow tests. And, you know, we frankly have reflected a lot and eaten our words on many occasions, but it was the idea of what is good enough. And what is good enough in primary care, in screening, is very, very different. And actually, for a service like pathology that provides services to primary care, secondary care, tertiary care, and so on, I think that's something that we really have to take on board.
And Jill, you mentioned about the cooperation and the focus and the talking with David regularly in that period. To what extent do you think that the kind of urgency and the perhaps risk aversion or the sense of energy and commitment that we found in that time of acute crisis, to what extent is that replicable or necessary as we now face this much longer term but equally as devastating problem of 7 million people plus potentially on a waiting list?
I think we all looked at things differently, because when we started this, I remember sat there one day and being told to try and procure thousands of tests, and pathology is very quality orientated, and we didn't know the quality of the tests, and like Neil said, what is good enough? Lateral flow is good for what you need it for. Pathology in-house tests are a gold standard, but you don't always need that, and it's about understanding that. But also we bought things not knowing whether they would work and whether we were suitable, and we were just building it as we went, weren't we? But we got there, and we got there relatively quickly, and I think we can do that again to pull back situations around elective work.
Would you say that, David, is that where the profession and system leaders are, the same sense of what's good enough is what's good enough and what works, and a sense of kind of energy and perhaps more risk appetite to make change?
Yeah, I think so. I think there's two parts to that. I think the first thing is, I think as Neil said, I think we as healthcare providers have probably become a bit more nuanced and perhaps less patronising, to put the right phrase, to start saying, look, actually, you know what, the right test in the right environment. So a phrase that we're using more and more is about point of need testing, which actually completely describes a very different set of settings that allows you actually to be a bit more risk sensitive to who you bring forward. So we see it with fit testing, with bowel cancer screening, for colonoscopy, etc. There's a prime example of actually using capacity better through actually being more relaxed about the cut-off of tests you're doing. And there's good clinical evidence to say that's a very robust and very sensible way of doing that. And there are lots more. Lateral flow testing to dictate whether you bring patients into a certain pathway. We had rapid testing, again, which is not the same standard as laboratory testing, to allow patients to be cohorted. So it's, there's a range of things that does that. That's the first thing. The second part is, I think we've now built the networks and the communication both at network level, at trust level, at regional level, at national level, that allows people to say, okay, well, what are our prime interests or our prime priorities that we really need to push forward to tackle that? And I'm sure it won't miss anyone here when you're talking about elective recovery. It's about, from a diagnostic perspective, it's about cancer backlogs. We know we saw whole streams of cancers which didn't present for a whole year during COVID. Now, where have those patients gone? They're going to come in a more complex manner later on. And so we know that we've got whole teams working across regions now saying, okay, well, how do we identify what workforce we require? What are the interventions for our workforce? What are the requirements on digital? And again, not going to a trust level, saying, can we please push a trust board to agree a replacement of a laboratory information system? We're saying, as a region, you need to replace or ensure your LIM system's up to date so it can do these things. And I think that has been a game changer. Now, again, I go back to the point, we're still not out of the woods, because we've still got to go through the pain of deploying all those things. Workforce isn't overnight. It takes a while, but again, working at a bigger unit scale, you can do more faster, and that's going to be the key intervention, I think.
Yeah. And are you optimistic about the news announced this week about direct referral pathways into diagnostics?
So absolutely. I mean, for my personal sort of interest, proactive diagnostics is the route to removing a whole echelon of costs out of the back end of healthcare, and also out in social care. A big challenge, because we've got to try and to dovetail budgets that sit in different silos, and hopefully the ICBs will be some route towards tackling that. But I think having diagnostic-led pathways makes utter sense. You know, being able to prime systems to say, well, this is the number I expect to see. Being a lot more nuanced, you know, being very data rich. You know, how many patients do I pick up via this route is almost becomes an easy answer to turn, as opposed to how many patients are referring to this pathway, how many were referred away, how many referred back into it, etc. You know, we start building a much higher level of granularity. So I think it'll pay huge dividends. I suppose my only concern, and it's one that we should all be mindful of, is of course direct pathways. You need to make sure you've got equality of access. Now, that doesn't mean everything should be the same. It just means that every patient should have the same outcome. And we've got to work probably a little bit harder when we've got those direct pathways on who's picking them up, who's taking advantage of them. Is there a socioeconomic advantage for some people to be able to access those? So that's going to be another challenge for us.
Neil, I can see you nodding, and you have a rich history of that kind of pathway change, I think, in your area. How did you go about managing exactly the risks that David highlights?
I mean, there's always been direct access to pathology services in what we do, because we provide services to primary care. I mean, I've got experience in radiology and managing radiology, because I was clinical director that covered radiology as well. And I am slightly more concerned about direct access for radiology. There's a limited estate in radiology. A scanner is a scanner. You want to certainly use it with the most appropriate referrals. Radiology presents another complication: the fact that you have IRMA regulation. And IRMA regulation is the guarantee that actually the request is justified. So you are justifying why you're exposing an individual to quite considerable amounts of radiation. So I think that has to play in, and those should not be shortcutted. I've said this again, I'm much keener on the pathway work, though. And the pathway work is the key to all of it. If we introduced a back pain pathway, everyone will be familiar with the pressure in primary care, and certainly to that. It reduced radiology requests by 50%. Now, for neuroradiologists, who are a rare breed, certainly in Coventry and Warwickshire area, but I should imagine elsewhere, that's freeing up a massive amount of capacity. So just free access to a system does not necessarily guarantee better outcomes. If we start to use that and use it in a calibrated way, I think that potentially has much, much greater value to it. And I think the notion that diagnostics, be it pathology or radiology, is about information. It's about information that moves the patient onto the next thing. That could be an outpatient referral, that could be surgery, that could be whatever. And I think once we start to elucidate exactly how that is, and it is on us in pathology or diagnostics to actually get out there and say it, I think that will actually put us in a better position. But there should be a free, well, not free entry, a direct access into pathways, not necessarily direct access into providing the test that will then create an additional pressure on those pathways, be they outpatients, elective care and so on.
What about the access point to that direct access? So if you can't get your GP appointment, if the routes into primary care are as congested as they are at the moment, what hope is there for any version of pathway change or direct referral onwards for that? I mean, is that going to be a barrier that patients will experience in your area, do you think?
So I think there's two elements to it. One is the digital infrastructure that David's just alluded to, and a lot of primary care systems have intelligent ordering systems that actually will take you along a pathway. So if you say, actually, I have lower back pain, actually that will align itself to a pathway, and that's definitely the way it should work. And there's nice guidance, and there's local guidance that actually should be able to support to support that. I've forgotten exactly what the question was, Ed. So
well, it was sort of about blockages into primary care? And perhaps I'll turn to Jill. And
Sorry, just on the other one is again taking David's point about access. So not everyone will access primary care services in the way that some of the disadvantaged populations will, and I'm particularly thinking of mental health and severe mental illness. We all know that those individuals will have quite severe comorbidities that are invariably related to access to healthcare because they're secondary morbidities that need to be. So we have to think about how we get out to those individuals to allow them access into the system.
are there any lessons, Jill, to share from your patch?
I don't know really, but I was just thinking about using the IT to triage patients. So rather than having to typically go and speak to a GP to do that, you could use IT to do that, couldn't you? And then that would put you, as you say, into a certain area or a patient pathway.
David?
Yeah, I was coming here because I think there's a bit of an open challenge here, both to the pathology community and also to people who design pathways. During the pandemic, if you asked me before the pandemic, could you trust the general population to undertake a nasopharyngeal swab to do a PCR? My answer would have been absolutely no. I wouldn't trust that whatsoever. But the evidence very quickly showed, actually, and I'll say this, I've got trouble saying it on, but it's true. Patients actually were better at it than the healthcare professionals are doing it, and it's because they're vested in it. They're vested in getting the right answer because they were. The message was clear. This will enable you to do stuff. So the investment on that test was a lot greater. And I think we need to be taking advantage of that situation, thinking about actually how do we get the general population, so there's not patients yet, to start monitoring their own healthcare and accessing those pathways in novel ways, absolutely, that actually helps triage them in a sensible way. And there's lots of stats around novel diagnostics, and we're not talking about tests here, we're talking about things that are diagnostic of. So, for example, people who, when presenting with ovarian cancer, often express certain symptoms, but very vague symptoms. So what are we doing about capturing that information and helping collate that into a risk stratification? And that may not be one that's ever coming up against a healthcare professional. So what is the route to do that? Going to Neil's point about mental health, statistics are that if you don't leave the house for 3 days and you don't open and you look at your mobile phone more often, your chance of suicide goes up by 80%. Now that doesn't mean that leaving your house and not always looking at your phone causes suicide. No, it means that people who exhibit those behaviours are that risk group, and you can prioritise those patients. So I think we've got to think a bit more laterally about what we mean by diagnostics, and I think that's an open challenge really, because it's the diagnostic tests in the laboratory only add value in the way they're used. There are other things that we might have to bring to bring patients and enable pathways. So it's a bit of a bigger challenge that was.
And on the scepticism of the clinical workforce, we've had a question just asking for more information and guidance, and I guess in your IBMS role now as well, perhaps with that hat on, how do we overcome the clinical scepticism in some of this change, both on pathway, on the concept of what works is what's good enough, and on the idea that actually patients can be trusted to be agents of some of their own diagnostics?
I mean, and we know that clinical change is a massive challenge. I think it's about having good examples. It's about being data driven. I always say, I represent a almost entirely scientific workforce. They love data. Prove it via data. They'll be your flag bearers from evermore. So I think we've got to make sure we collect that data, and that goes back to the digital perspective. Unfortunately, we're very poor with our diagnostic data in the UK in terms of collating into a usable format that allows people to take and draw assumptions from. If you go to fee-paying states where healthcare systems are fined for not identifying illnesses, they have algorithms designed so they pick up patients, and it's all to do they'll get fined. Not for patient benefit, I'm unfortunate to add. However, the system still works. It still goes out there and says, we haven't seen enough gestational diabetes in our population. What do we do? What's the intervention now? And I think that's the bit we need to do.
Teresa, just if I could ask you about the notion of kind of consumer healthcare and the kind of personalisation and ownership of diagnostics, which was unleashed during COVID. Who'd have thought that people would be able to, tell their PCRs from their lateral flows and all the rest of it? What's the actual legacy from that in practical terms? What is industry doing to support that in terms of products and product development and research, and how optimistic should we be that that change will be a permanent one rather than something we will kind of fall back into old habits following?
I think it's fair to say very optimistic, and I think it's a really good point that patients, when they have a vested interest, can and do these tests really well. I think there is a lot of opportunity, and I think it is a case of kind of the right situation and the right test. I think there are clearly times when we need that gold standard that you talked about, Jill, and I think there's other times where good enough is good enough. And I think as we look at an industry level, us and our peers, I think we're trying to identify the right solutions to be offering, and making sure we don't contradict, I suppose, some of the other things. So a key area right now that we're looking at is home HPV testing. Huge burden on the primary care scenario. Is that appropriate? I think that's some work NHS England is doing to see, actually, could this be done at home? Will it inform the pathway? Will it make sure that we're capturing those patients that don't appear in primary care, don't present? And will it take some of the burden away so that we can concentrate? So there's always a balance, but I think what it's opened up to industry, I suppose it's opened our eyes to say that traditional diagnostics route that we've always supported, there may be other options, and we need to kind of be broader. I don't think point of care testing is the answer to everything, but I think it clearly has a place, and actually can really improve patient flow, can really speed up some of the decision making that is causing this backlog.
Are there, as a clinician, Neil, what are the areas, we've talked about HPV, FIT testing, what are the kinds of pathways, disease areas, categories of need and diagnostic where you're particularly optimistic, and people here who are either making decisions on national budgeting or looking at pathway change at a local level should have at the top of their list in terms of the opportunities here?
So again, I don't think it's that difficult. So certainly each ICB or system will have worked out what those health priorities are. As CCGs, they had all worked those out, and those are the priorities. And I think, frankly, we have an awful lot of testing that is applicable to those pathways. There may be different issues about access, about capturing those individuals, but actually it is about tailoring our service to those requirements. An example I will often give will be adolescent diabetics. They are the group that are most unlikely to self-monitor, that are most likely not to attend because they've got a million better things to do. Aside from the fact of they may not be willing to share that they are diabetic with their friends. So actually how we reach those individuals. So home testing actually could be a route to that. And again, I'm a great supporter of certainly home HPV testing, but actually we have rolled out really successfully bowel screening, which is a complex thing and it's not that appealing, but actually 70% uptake is a really, really quite an impressive screening area to look at. So again, maybe this is actually about trusting individuals and pathology or diagnostics playing an oversight role in assuring that actually we're doing the right stuff, where the quality is assured, but actually trusting other individuals to do it, either directly or with their carers. And I think we don't talk about the carers who actually allow greater access to those individuals who maybe don't access the services normally.
Yeah, in terms of point of care testing or home self-testing, where are the pathway opportunities or the disease area opportunities in your area, and how progressed are you in driving that?
I think, like Neil says, I think there's a lot around diabetes, there's a lot around fit. I think one of the things we do need to get right as well is phlebotomy. Phlebotomy is, you go to your GP, you want a blood test, he gives you a blood test, and then you have to wait weeks for a phlebotomy appointment, and that's, you know, the delays in that. The actual pathology element in the laboratory is literally hours, and you've waited 3 weeks for your result in the phlebotomy episode.
David, I mean, that's been a point made on phlebotomy for some time, and you can read Richards, who kind of might kind of goes over the same terrain. Why has it not happened to date? What are the sort of blockers in the system, particularly with your former hat on?
So what are the blockers in the system? I think home sampling or phlebotomy, but that part of the pathway has been long neglected, and it really is a genuine Cinderella service. I think I go back to the days when I was an operations director for the pathology service at Guy's and St Thomas's, and I was told that I'd be managing the phlebotomy services. Guy, that was awful. You think so? I don't want that. But actually, it was a public-private joint venture, and actually time and money was spent on working out actually how do you optimise your phlebotomy service. As Jill said, that is often the bottleneck. Our labs in the UK are some of the best in the world. Your turnaround times in your labs are phenomenally short, and actually we can push through an awful lot, particularly in terms of blood testing. But you wait too long for your phlebotomy. You can wait several hours in the outpatients just to have your blood taken. Now, if you can smooth that pathway, you can actually save a lot of money down the other end of the stream. And again, my own example would be, we used to run a night shift of about 5 or 6 biomedical scientists. We took about £1 million off staff pay by optimising our phlebotomy flow. So we got all our samples into our labs much earlier during the day. And that's a phenomenal change. That can happen anywhere. And if we're able to use CDCs in a better way for people to turn up to have phlebotomy taken, then you can remove the need to be home tested, because you know what? You need a blood test, here, go and have a blood test. In fact, you're going to go past Tesco's and they'll do it for you there, for example. And that's the sort of thinking we need to get into. And then those direct pathways suddenly become a lot more sensible, because suddenly you're saying to patients who require that, it could be a phone call, it could just be like, please go and have a blood taken and have these few tests done. That makes a big difference. Equally, when we're talking about access to different things, so we talk about imaging, if you need contrast media and you haven't had an assessment of your kidney function, so a creatinine taken, then why wait, like you said, several weeks to get a creatinine taken? For then you have to schedule that together with your imaging appointment and hope that within 48 hours or so that result is available. Well, why not free up some of the capacity elsewhere? Use the right test for your creatinine in the CDC, and then give patients a test that's good enough to say whether they can have contrast media or not, and move them on, and not take up a room for a diagnostic test as opposed to an operational one. So that pre-analytical piece is really important, and it's been massively neglected, but actually has a massive opportunity to change things. And I'll just touch on one last thing. The workforce with phlebotomy, again, highly trained in phlebotomy, but also highly trained or highly competent to be trained to be doing other things as well. So there are other diagnostic steps, spirometry and others, that could all be done at the same time, but with that workforce. So build a pocket of workforce that is providing that diagnostic entry point would actually also be a game changer. So it's not in any way just improving phlebotomy. It could actually be a whole load of other components that improve that part of the pathway.
So on CDCs, and I'll come to everyone for an answer on this question, but as you've said, there's the potential for them to be great agents for change in some of the things which as a patient you would be most frustrated by, put at unnecessary risk by, suffering unnecessary delay and additional queuing, and phlebotomy is obviously a really practical example. To what extent are you confident that the much vaunted CDCs are going to deliver that kind of change everywhere or in most places, rather than end up being, as we've seen with other kind of well-intentioned initiatives, kind of ancillary adjuncts to existing services which don't fundamentally change the patient experience or pathway, or therefore kind of productivity or efficacy of something?
So I think it all depends what pathways go in them, and also what the assumption of what a CDC should do. I think, so Ian's touched on it, in terms of imaging capacity, we don't have sufficient, and actually having planned cold capacity is the game changer for the CDCs. So in the imaging pathways, I think it is a real game changer, because it's taking it all the way from the acute sector that is trying to fit in the acute imaging, etc. So that's a really big change. I think for pathology, I think if you're thinking of creating a whole new laboratory inside your CDC, you've barked out the wrong tree, and actually you're going to pay twice for it, you're not going to see the benefits you need, and actually you'll see testing being repeated because of the standard or the quality results being derived. So I think it's about phlebotomy, logistics and imaging. Those pathways that meet those sort of like base criteria are the ones that are going to see DC, and they will benefit most.
Neil, one ICS lead who I won't name, and I don't think he's sat here, said to me that they basically were trying to refuse their CDC money because it was not worth the fight locally, and the trust didn't want their staff having to go over and be stretched across another site, and it wasn't the thing that they wanted to do, and they had a different model in mind. And the politics of trying to get everyone to agree to who ran the site, all the rest of it was too. Obviously, that wasn't in Coventry and Warwickshire. Tell us, are you going to make a great success of this, and what can be learned, and what's your overall optimism about this kind of on the national front?
So I think the CDCs, as they were intended, was almost a referral point in that would support earlier diagnosis. So, I mean, I think we've got to get back to the purpose of it. So earlier diagnosis, and I think we all would agree that earlier diagnosis will lead to more rapid treatment and therefore prevention of some complications further in the pathway, and thus avoid cost. It was always a principle. It was based on the fact that actually we image less than a lot of our counterparts, certainly in Europe. But I would go back to my point, and actually David's point as well. This is about access. This is about pathways. So if we are just creating a new building elsewhere in Coventry that is going to do more scans that we cannot do on the acute site that people queue up for hours for, then we will have failed. If we actually do the CT in a pathway and we look at what the next step is, then we will have achieved something. I think regarding pathology, I think there's an opportunity for us to work in almost a virtual CT. So if we have pathways that are AI driven, actually you want to be able to access your blood test in Tesco's. You want to be able to access your blood test somewhere, or have a referral test on the basis of your original blood test, and that has to all be within the pathway. And we've talked an awful lot about, not we here, about infrastructure of CDCs, the capital that we cannot spend. I don't hear very much about pathway development through CDCs and using them optimally, and I think that's where one of the next focus should be, and I would certainly hold a hope out that the ICBs will grasp that type of thing, because that's where the real savings are.
Jill, is that fair in your patch, and then perhaps Teresa will come?
I was just going to say, I think we should think about the CDCs. I think we should think about the workforce in the CDC, that not necessarily should be just aligned to traditional boundaries. So somebody can have the competency of being a phlebotomist with a competency in imaging as well, and make the best use out of what limited workforce we have, and align those to pathways.
I think David made a really good point. I think we have to just, I think they will be invaluable. I think we just have to be careful that we don't double up our workload, and we really focus on them being an effective part of the pathway rather than an efficient push more patients through and end up repeating things. I think that's the kind of key, is integrating and making sure that that feedback loop is really, really a kind of really comprehensive, I suppose.
Jill mentioned the topic of workforce, which perhaps we'll come on to, and come to you first, David. Most of the political and national and financial attention goes on doctors, nurses, and a whole load of other valuable health professionals kind of left behind, and actually the laboratory and biomedical science workforce is often, is it fair to say, kind of underappreciated, underinvested in, and undersupplied? And is that your view at the moment, and to what extent is that going to be a limiting factor on all of the transformation that we've just been talking about?
So I'm health warning. I'm a biomedical scientist, and I'm chief executive of an organisation that looks after them. So I'm going to say this, aren't I? But yes, I think the healthcare science workforce, so it includes clinical scientists, biomedical scientists, and those who sit in other healthcare science disciplines, is hugely underutilised workforce. They have a huge amount of capabilities. We know that if we talk about cancer pathways, we know that there is a shortage of medical histopathologists, but actually there are pathways for consultant equivalent scientists to be on a par with certain pathways of reporting. So we know we've got about, I think, 30 with a further 60 or so within England, individuals being trained to report pathology as if they were medical consultants. And I think we need to do a lot more about making sure that we're using our workforce in the right way. We have consultant grades right across in all disciplines, and the better they are used to free up the medical workforce to where they add the value, we will not tackle this backlogs in cancer, but also we will not improve our position in the worldwide status of cancer outcomes. So I think my plea to anyone here is think about your healthcare science workforce. Actually, they are fully competent, they're regulated, they're highly trained, they're highly capable. We're not making best use of them in the main. And there is, unfortunately, a time lag. I think we're talking about several years to close the gap in terms of training individuals, but there are not actually a short supply of professions. So in terms of biomedical scientists, biomedical science, those who are qualified for entry, actually we have a dearth, and we don't actually bring most of them into the NHS. They're funded largely outside that. But when we push them through the system, attrition rates are quite high, so we do end up with shorter supply within that. And it's because routes to progression, routes to developing their clinical skills, etc., are lacking. So they say, well, actually, I've got to this point and I'll leave. And actually, there's, if I give you a couple of examples that may well be on people's radar, not only in cancer but in genomics, there's a whole echelon workforce who do not progress past band 7, and yet they are PhD individuals. They have individuals with a solid research background, and they'll choose to leave because they have no route to progress into a more senior clinical role. And that's a travesty, actually, and I think we need to do a lot more around that. And again, that closing the gap about the right people doing the right things will be the answer. Because actually, if we've got people reporting things, or we've seen a massive success in cervical screening, it is now quite unusual for a medic to view a cervical screen. Very unusual. In fact, actually, for the last 20 years, it's been done by scientists. That can be applied into histopathology, it can be applied into biochemistry, into hematology, etc. And so I think we've got to do a lot more of that, and that frees up the medical time for clinical practice elsewhere.
And how does that change get led, Neil, at an actual institutional or a local level, and what are the difficulties in that?
I think it's at an institutional level, a local institute level. But I think it's also about those leaders stepping up and saying, we can do this and we want to do it, and obviously being savvy enough to exploit it. I recognise a lot of what David says, and that's absolutely right. I think also we have to, as pathology or as diagnostics, innovate more. So yes, we are innovating in different professions, are looking at slides, and that will improve pathways, and that will help elective recovery, and absolutely we get that. But there is AI coming through, so there's a huge program like digitalization and histopathology. I would say that we did not take advantage of the digitalization in radiology as much as we could, and we are in histopathology. And we as an organisation adopted digital histopathology in 2015. We are starting to look at the first algorithms that will actually be able to identify normals, i.e. non-cancer patients, and it is in clinical trial. And that's actually 7 years after we adopted it. And the people leading that are the people that people are frequently branding as very conservative people, the consultant histopathologists. So I think it is talking to those individuals about stuff that actually matters to them, rather than going back to network development, saying, yes, this will save 5% CIP or something like that. Actually, to improve the service is what people really want. And David's quite right to mention genomics. If you look at an MDT agenda now, it is all of diagnostics coming through. So we still need diagnostic experts to bring a lot of that together. So I don't think that there is the nervousness amongst some of the histopathologists, some of my histopathology colleagues, that say actually this is going to do us out of a job because there's tons of other jobs to do.
Ed, can I just, sorry, I just kind of wanted to come in on that. I think as somebody in industry, I think even 5 years ago, there was a nervousness about talking about automating. I think there was a nervousness about people feeling their role was moving, but I think now more than ever, the benefits of the reproducibility you get through automation allow your teams to really actually focus on where they add value, rather than the kind of factory-like processes that need to happen. And I think that is a real step change, you know, that we've seen in the last maybe 5 years or so, is that realization that automation actually allows that value add, which is so much more important.
And that allows the workforce to innovate rather than just push buttons in automation. You know, that gives them that time to free up. And I think as well, we need to be more savvy in developing our workforce. I think, you know, nurses, midwives have had a long history of CPD money come to them, not so much healthcare scientists, and we need to develop them so that they stay within our profession and develop and become our future innovators and leaders, and not leave because they don't feel, you know, invested in.
In terms of the capability of networks to lead on some of this, so things like automation, being able to look at to run the change management as well as being able to hold the investment required, or workforce reform and development. The principle of the networks operating at more scale to be able to drive some of this is obviously integral to the vision. Where are we on the maturity of those organisations and their focus, do you think, to actually make progress here, and what stage of the journey they're on? Perhaps you might both have a view on this, and it may be a different one.
I'll go first. So I have another role, which I'm the scientific lead for pathology for London region. So I get to enjoy the helicopter view of networks, and I would say networks in London are far more mature. Not for any other reason other than the fact they've been around longer, and they are starting to see the benefit of actually being able to work not just as networks in terms of scale of procurement, in terms of hub and spoke or procurement of similar identical systems across their patch, but also starting to see the benefit of combined workforce development. And I mentioned about the advanced clinical practice scientists, they need to be exposed to a certain level of workload and style and cases, etc. And you get that from combining several hospitals worth of work into that. And for London region, they're starting to look actually to work as a whole region, some of that development piece. And that's been allowed because of the networks have got to the point of saying, look, actually, I know what I need, my workforce, I can only deliver this much, but actually if I work with you, I can deliver twice as much together. We can do this together, because I'll concentrate on this part, you concentrate on that part. So I think from that perspective, yes, that is making a difference, but that's from an area where networking has been around for a lot longer and the journey is a lot more matured, but I'll perhaps...
We have some national programmes around scientific training programme, high scientific training programme, and I think we should think of those more as regional trainees rather than aligned to particular trusts, and the fact that they can go around and experience work from in pathology departments around the region, train them as regional people or even national people, and see them as being an aid to a region rather than employing them as a single trust, going through a training position and then possibly not having the job from the end. Think wider as to how we employ these people.
Could I just quickly come in? It's a bit of a pushback. So yes, of course, network maturity is absolutely the right thing, but actually system maturity is also got to be considered alongside. So David alluded to, there's massive digital investment. During December, I will take a business case an outline business case for a new laboratory information management system for the South Midlands Pathology Network to 7 boards, 2 ICBs and 5 acute trusts, and all of the infrastructure that feeds those boards. That's just eye-watering in terms of time. I mean, but that's real. You know, we all want to have interoperable pathology. We all want to have the stuff. Actually, how are the systems going to help us deliver that? And that's frequently what takes the greatest time, and that takes the most leadership in terms of time. So really, I think the question is back. I think networks are going to become more mature, but as they become more mature, they realize their governance constraints. And therefore, actually, will push back to the centre and say, no, we can't get this approved because of X, Y, Z, but also have to then work within those systems. And it's right, we should work in the system, because it's right that we should integrate with the ICB's digital strategy and so on and so forth. But, it's torturous at times.
I've had a similar sort of thing. I mean, we went out to tender for a single IT system in Lancashire and South Cumbria, and we've awarded it. But it took a long time, like Neil says. We had to go to all the finance and investment committees for each trust, go to a board, go to, and it's getting rid of and cutting through some of that bureaucracy and behaving as one system rather than, and giving us accountability for it. We know what to buy in the way of limbs. We know what we need. Let's give us the accountability to cut through some of that and procure it quicker, and also deploy it quicker once you've got there.
A cynic might say that in places we've replaced a tortuous process of commissioning, contracting and procurement with an internal governance process that's equally as painful and in fact involves even more bodies in places. I mean, you haven't even mentioned layering on kind of imaging networks or cancer alliances and other actors in this. What would be the plea to national leaders about how to reduce the torture involved in trying to navigate the systems and structures as they find their feet? And that's a question to the panel, but why don't you go first, Neil?
Mine would. So I think mine would be to highlight the point that I've just been making. It is not a good use of resource to go to 7 boards and all of the infrastructure that goes there. So therefore, when we are looking at reducing waste within systems, that would be a way of doing it. Now that involves trust and communication. And that is perhaps the greatest gift that ICBs can do to try and generate that trust and collaboration. There's so much vested interest, not just in pathology, but in so many other areas and so many other contingencies there. But there's something about the trust and collaboration, and use stuff like that as examples. So how would we agree? How would we get through systems, a complex, and we're looking at 15 to 20 million pounds worth of procurement, how would we get that through? And use those examples to try and break down some of those walls. But ultimately, I'd like to go to one board, which probably would be the system board, because I think that's where some of the governance around networks is going to be. And then that system board works out a way of feeding back for individual trusts, for their capital registers, and so on and so on.
Does anyone else want to comment on that?
I was just going to say, I think we need to be less reactive over capital as well. I think we get to January and somebody says, we've got some capital, can you spend it before the end of March? And it's incredibly difficult to do that. So a bit more planning.
Is it deliberately difficult to do that at times, David?
Not by anyone in the centre, I'm quite sure. No, but I mean, I think it goes all those sort of things, isn't it? Just early doors post-pandemic, we saw phenomenal amounts of money being awarded because of the challenge we saw around the digital connectivity of the system. We saw phenomenal amounts of money being awarded, and it's upwards of many hundreds of millions of pounds of monies put forward for digital, and we had something like under 6 months in which to spend it, and it just isn't feasible to do. But it goes back a little bit, perhaps, to your initial question of what's the change. The change is we're not always. I don't think we've necessarily got the structure right of where pathology sits within the system. It sits primarily within secondary care. That's where its budget is, but it's actually half its service, if not more, is coming from primary care. And actually, I'm wondering whether we need to be thinking of pathology as we do with other entities as something slightly different than just between acute or primary care, and perhaps giving pathology a different worldview or different position might enable it to manage that money differently, to allow for multi-year accruals and not expecting trust to accrue that money when they've got other deficits and things to balance against. Now, I mean, again, this is a huge step. There's two things. One is, are we talking about a nationally commissioned pathology service? That could well be one of the answers, couldn't it? And that would fix a whole range of problems. It would also cause a whole echelon of other problems, I know, so not naive that one. But that's one way of tackling that large amounts of money spent in the other ways. And the other one is thinking more about the contractual nature or the organisational structure of the networks themselves. So again, and again, I bear no complete indifference between public or private, having worked in both. But actually, when an entity has the ability to control its own strategy, to manage its own budget, to lead its own challenges and priorities, it is a different organisation that can do different things. And at the moment, we have pathology services that sit within, and you know, all due respect to everyone in the room, it often sits right down here in terms of priorities, because actually, you know what, it often runs well. There's no major problems on the whole, a few pinch points, but actually I've got much bigger problems up here. Give that to someone else to say, right, my biggest pain point is how do I roll money over, or my biggest pain point is how do I manage my capacity. And that really is a different model, and it really does make a difference. And I've seen models at both public and private and public-private ventures that have their own entity, and that is the game changer. And I wonder whether that is the point.
Interesting, thank you. Look, we have run out of time, but I just will look up to the audience in case there's a hand up and anyone has a question for the panel, which I can't see. So look, it just leaves me to say thank you. Thanks all for joining. Thank you very much, Neil, Teresa, Jill and David, for being such frank and well-informed and informative panellists. And yeah, wish everyone a very good rest of the day.